to the
This
demo.
was really good. A 34-year-old engineer presents to our emergency department with dyspnea and a heart rate somewhere between 125 and 140 per minute. You can see why the heart rate is high. He has atrial fibrillation with a rather rapid ventricular response. Okay, now let's pause here for a second and let's look at some of the details and some of the information in the background. A large healthcare provider in the US reported over a 12-year period 2.7 million visits due to atrial fibrillation. This meant that there's an increase from 0.6 to 1.2 per 1,000 people in the US. And 14% of these patients had congestive heart failure. So what is the message here? Well, atrial fibrillation is a frequent condition, it's on the rise, and it's strongly related to heart failure. Now, why is this so? Why is heart failure related to atrial fibrillation? Is it the cause or is it the consequence? Is it the chicken or is it the egg? Now, there are many, many different conditions that can cause atrial fibrillation. If you have poor left ventricular function or some form of left ventricular disease, this causes a strain in the left atrium, which leads the left atrium to increase in size, and eventually the result will be atrial fibrillation. So you can have cardiomyopathy, hypertensive heart disease, valvular heart disease, coronary artery disease, myocarditis, pericarditis, endocarditis. All of these can cause atrial fibrillation. So I think you know what teaching point I'm trying to make, right? We need echo. And sometimes you'll be surprised what you can find in an echocardiogram of someone who has atrial fibrillation. Now, this is a patient who had intermittent atrial fibrillation. Now, she's in sinus rhythm. But take a look at the structure right here. A large thrombus which comes out of the left atrial appendage and which reaches almost into the left ventricle. Now, I'm sure you wouldn't want to put a defibrillator on her and cardiovert her without trying to get rid of that thrombus first. So, there's a lot of information in the echocardiogram in patients with atrial fibrillation. Another example. Here is a patient with poor left ventricular function and a patient with normal left ventricular function. It's also important to know this because, after all, tachycardia can cause cardiomyopathy. We call it tachycardiomyopathy. Or maybe the patient has underlying cardiomyopathy, something which is also important to know with respect to which medications you would give the patient. Let us come back to the patient, however, that we started out with, the 34-year-old engineer. This is his echo. Again, a very surprising finding. What do you have here? Well, a very, very small ventricle. It's almost non-existent. But what you can see in turn is that the myocardium is extremely thick. You see that it's almost, I would say, a loaf of meat. This is a patient who has a specific diagnosis, that of hypertrophic cardiomyopathy. And these patients are also at risk of developing atrial fibrillation. And usually atrial fibrillation in these patients is very symptomatic because they have a small heart to start out with, and they need the filling of the ventricle via the atrial contraction, which is now missing. So, very important information in this patient. And the consequence, of course, would be that you need to rapidly cardiovert him to get him back to normal. So the hallmark of left ventricular hypertrophy is a thickened myocardium. And the most frequent cause of left ventricular hypertrophy is actually arterial hypertension. Now, left ventricular hypertrophy is a very important feature. In the AFFIRM trial, which looked at hypertensive patients, we found that patients who have left ventricular hypertrophy have a higher all-cause mortality and have a much higher risk of stroke. In other words, it's a predictive factor. But how does left ventricular hypertrophy look on the echocardiogram? Well, basically you can see it in many views, such as this parasternal long axis view. Right here you can clearly appreciate that the septal thickness is more than normal, more than 11 millimeters. That is the cutoff value. Why does the left ventricle hypertrophy? Well, the reason is clear, because the ventricle wants to reduce the wall stress that it has because it has to pump against a certain resistance. And to do that, the ventricle gets smaller, and at the same time, it hypertrophies. That is the mechanism by which the wall stress decreases and the ventricle is capable of putting up with the higher afterload. So in essence, it's very similar to someone who trains and trains his muscle. But it's not only arterial hypertension which causes hypertrophy, it can also be aortic stenosis. We've talked about aortic stenosis in the previous chapters, and the reason why we develop left ventricular hypertrophy is very similar to hypertensive heart disease. Now we have a stenotic valve which increases the afterload and thereby increases the wall thickness. Aside from aortic stenosis and hypertensive heart disease, we've already seen hypertrophic cardiomyopathy as a cause of left ventricular hypertrophy. But there are other reasons as well. For example, patients who train a lot, who are athletes, can also develop left ventricular hypertrophy. Now, in this case, it's a physiologic reaction. And furthermore, diseases such as amyloid heart disease, which are infiltrative diseases, can also cause left ventricular hypertrophy. But before we go into more details of different diagnoses, we first have to learn how to measure left ventricular hypertrophy. We need to go to the machine.
Do you want to assess left ventricular hypertrophy? I will show you. It's really easy. First of all, I will use 3 views: parasternal long axis and short axis view, and then apical 4-chamber view. So when you get good parasternal long axis view, you see the hypertrophy is measured looking at the septum, and the measure of the septum you have to take during diastole. So at end diastole, you can help yourself with the ECG. I would measure the septum here. Remember, it's extremely important not to include in your measurements chorde tenine or segments from the right ventricle. So make sure you have the real measurement of the septum, which for our patient is 11 millimeter. The same measurement I would have in the short axis view at the level of the papillary muscle. This view is extremely important when you want to assess the symmetry of hypertrophy. So for instance, when you have hypertrophic cardiomyopathy and the septum is involved, this is a key view, I would say, to understand. And again, I would perform my measurement. They match, as you see, here's 12 millimeter. And the last measurement I would perform in the apical 4-chamber view. Remember to really carefully look at the apex, because there are forms of hypertrophic cardiomyopathy where only the apex is really thickened, and here again we have 12 millimeter. 12 is a borderline value for an healthy individual, but our model is an athlete, so we can consider this value absolutely normal.
So the cutoff value for left ventricular hypertrophy is 11 for the interventricular septum. Okay, a millimeter up or down are sometimes very difficult to detect, and in essence, it does not make a difference if you might miss a mild form of left ventricular hypertrophy. But I'm sure you will all catch this case. A patient who had long-standing arterial hypertension. He was on dialysis because of kidney failure, and in this patient, we have a septal thickness which is somewhere in the range of, I would say, maybe 18 or 19 millimeters. In this case, you might not even need to measure. You can just eyeball left ventricular hypertrophy. Just for comparison purposes, here on the left is a normal left ventricle, and on the right, the patient we just saw. There clearly is a large difference, and this just shows you that very similar to eyeballing left ventricular function, you can do the same thing for left ventricular hypertrophy. We talked about the risk of left ventricular hypertrophy in stroke and all-cause mortality, but there's another risk, and that is that of coronary artery disease. And it's clear, patients with LVH have hypertensive heart disease, and hypertensive heart disease is strongly related to coronary artery disease. Now, this is the angiogram of the patient we saw previously, the patient with this massive LVH. And I think it's very clear that this patient has a high-grade stenosis of the proximal circumflex artery, which is just being dilated. This is the guide wire. And the entire vessel is diffusely alterated. So a beautiful example of how left ventricular hypertrophy can, I would say, not predict, but at least show us that, or propose that coronary artery disease is present as well. And a further implication of left ventricular hypertrophy is that of the small ventricle and the stiff myocardium. Here's the heart of a hypertensive patient at autopsy. You can appreciate that the patient had myocardial infarction. There's scar tissue here. But the other important finding is that the ventricular cavity is very small, which helps you to understand why patients with hypertensive heart disease and severe LVH have filling problems. The ventricle is very stiff, and it's difficult to get the fluid into the left ventricle. This means that the fluid management of these patients is often very, very difficult. And another important finding is that patients with LVH more frequently have ventricular fibrillation and sudden cardiac death. So LVH in itself is a risk factor, not only in patients with hypertrophic cardiomyopathy, but also for those who have hypertrophy of other reasons. And finally, why don't we just take the ECG and detect LVH with the ECG? Well, we know that the ECG is relatively low with respect to its sensitivity and specificity. Now here you might say, okay, there could be some degree of LVH because the Sokolov index is just borderline, but if you look at the corresponding echocardiogram, you'll be really surprised how massive LVH in this patient is. You see that there is a septal thickness probably of somewhere in the range of maybe 17, 18 even in the septum. And what you can see very nicely is that the patient has hypertrophy of all segments of the myocardium, here in the short axis view and also in the four-chamber view. We call that concentric LVH, especially if it happens in the setting of a rather small ventricle. And concentric LVH is a typical feature you will have in most patients with hypertensive heart disease and aortic stenosis. This is not the case if you have hypertrophic cardiomyopathy, and this is one of the most important ways of distinguishing the two. Take a look at the myocardium right here. You see that this part of the septum is much thicker than, for example, this part. The septum here again has larger diameter than, for example, the lateral wall here. And such patients very frequently have an additional finding, a finding that we call SAM, which is the abbreviation for systolic anterior motion of the mitral valve. This apical long axis view shows you exactly this. Take a look at the mitral valve here and see what happens to the mitral valve at the moment when contraction occurs. Part of the mitral valve, the anterior leaflet actually, is drawn towards the septum, and so it occludes the LVOT and causes obstruction of outflow out of the ventricle. You can nicely see that here in this still image as well. This is the part where the ventricle is practically occluded. So we have obstruction of flow out through the ventricle. If you use color Doppler, it's possible to visualize that as well. You have high turbulent flow here in this region where the SAM occurs. Not at the aortic valve, but already here in the LVOT, the outflow tract. So patients with this phenomena are called obstructive hypertrophic cardiomyopathy. In the masterclass, we'll then talk on how we can actually quantify the degree of obstruction. It's very important to know if a patient has hypertrophic cardiomyopathy or not, because some patients need treatment because they could be at high risk of sudden cardiac death. Approximately 1 in 500 people have hypertrophic cardiomyopathy. In some, it might only be a very mild form and the patients don't have a poor prognosis. But nevertheless, the risk of sudden cardiac death is estimated to be somewhere between 1 to 50,000 to 1 to 200,000 per year. But athletes, or those who participate in competitive sports, are at high risk of developing sudden cardiac death. In a study, it has been shown that a little bit less than half of the population with sudden cardiac death during athletic sports had hypertrophic cardiomyopathy. Now, echocardiography provides a lot of information that helps you determine if patients are at risk. If you look at this chart, which shows you the different risk factors, you can see that left ventricle wall thickness, left atrial diameter, the presence of an LVOT gradient can all be found or looked at with the help of echocardiography. I want to provide you again with some examples. A patient with hypertrophic cardiomyopathy, small ventricle, as you can see, again, the septum is very thick. It has a speckled appearance, a feature that you can frequently see in these patients, even though it's not very specific, I would say. Again, compare the thickness of the septum with the thickness here at the lateral wall. Take a look at the motion of the mitral valve. Again, the anterior leaflet is drawn to the interventricular septum. The patient also has a large left atrium, a frequent additional finding. If you now rotate the probe and look at the apical long axis view, it's again nice to see that the patient has this systolic anterior motion. Left ventricle function is normal, but remember, you always tend to overestimate left ventricle function in the setting of small ventricles, and you will also do this in patients with hypertrophic cardiomyopathy. What about this patient here? The septum looks quite normal here. It's not thickened at all, and neither is the lateral wall here. You have to be very exact in imaging to display the apex though, which clearly shows that there's a lot of hypertrophy right up here. This form of hypertrophic cardiomyopathy is called apical hypertrophic cardiomyopathy. It's more frequent in Orientals. And here is an example of a patient who has rather poor image quality. And you have to, again, look very closely to determine that the interventricular septum, again, is very thick, you see. And, again, there is obstruction of the LVOT, again, a SAM phenomenon. So here's with some of the examples of the different variation of how hypertrophic cardiomyopathy can present. And believe me, all patients look a little bit different, but they still have the common features of asymmetric left ventricular hypertrophy, of small ventricles, sometimes LVOT obstruction, left atrial enlargement, speckled appearance of the myocardium. With this information, it is now your turn to tell me, or to tell yourself actually, if these patients have hypertrophic cardiomyopathy. Here's the first case. Remember what you learned? Look at the size of the left ventricular cavity, look at the myocardium, also at the motion of the mitral valve. Okay? Well, I think this is a pretty straightforward case. It's a no-brainer, I would say. This is massive LVH. Look at how small the cavity of the left ventricle is and how massive LVH is. This is somewhere in the range of, I would say, maybe even 30 millimeters. And the entire myocardium is affected. Here you have complete cavity obliteration. This is an extreme form of hypertrophic cardiomyopathy, and you would never see a patient with hypertensive heart disease with such extreme form of left ventricular hypertrophy. But what about this case here? Now, again, is there hypertrophy? Certainly not down here in this region. Right? It might be difficult to say what is going on right here at the apex, but this looks quite normal. Well, still I would suspect that there is an apical hypertrophy here. But to confirm this, what we did in this case was we injected contrast. And with contrast, you can nicely see that truly hypertrophy extends here all the way to the apex, and that there is, I would say, fluid or blood accumulation here or capture here in the systole due to obstruction at the apex. So, certainly nothing which is hemodynamically relevant, but it just shows that hypertrophy is present at the apex and that our suspicion of hypertrophic cardiomyopathy, of apical hypertrophic cardiomyopathy, was correct. Okay, now with these loops, I think it's time that we see an actual patient. Are you ready? Can you help us to find out what is wrong in this young individual?
Well, I'm starting the exam with a 4-chamber view, apical, and I think mitral and tricuspid valves are okay.
Yeah, the valve looks okay. Is there maybe some regional wall motion abnormality?
Well, from the 4-chamber, I think there's not, but I'm showing you the 2-chamber view.
Mm-hmm. Okay.
And again, I think there wall motion abnormality is not a concern.
But go back to the 4-chamber view because somehow this heart looks a little bit strange.
Yeah, as far as the interventricular septum is concerned, actually it looks bigger than normal, and we would expect in a young person. So,
I mean, this is, in my view, visually by looking at the left ventricle a hint for left ventricular hypertrophy. But we still need to confirm this finding, and we can do that by measuring.
Yes, exactly. I will stop my frame in end diastole. I will measure, and we get interventricular septum of 15.
Now, this is the position that I would measure as well, but beware that sometimes you have a little bit of a bulge there. So I would probably measure it somewhere below the bulge, or at least consider that it is not representative for the entire thickness of the myocardium. So it sometimes can be a little bit tricky to measure the interventricular septum. And if it doesn't work in a 4-chamber view, my suggestions would be to use a parasternal long or short axis view.
Exactly, and here, for instance, is not the ideal patient for it, but we can still confirm, because again, the measurement, I'm sure, will be close to 15 millimeters. Yeah.
Right, so 15 millimeters, that means that the patient has left ventricular hypertrophy, and if he is not an athlete, the possibility is very high that he has hypertensive heart disease. So the next time you perform an echocardiogram, don't forget to look at left ventricular hypertrophy. To summarize what we've learned in this chapter, LVH is very common. It's frequently associated with hypertensive heart disease, and you will find it in patients with aortic stenosis. Those are the two most common causes. We diagnose it if the septal thickness is more than 11 millimeters, and you can measure it with the help of 2D imaging. And if you want to make the diagnosis of hypertrophic cardiomyopathy, it requires that you have an asymmetry of hypertrophy, and in such patients you would frequently find LVOT obstruction. And don't forget that these patients are at risk of sudden cardiac death.